Bienvenidos, hola, mi nombre es Ricardo, yo uso los pronombres she y ella. Soy miembro de Public Health Committee de MOLA y estudiante de medicina en Northwestern Feinberg. Me gustaría agradecer a todos por venir a nuestra reunión viendo los colores de Arcoíris. So in honor of the LGBTQ plus History Month, we want to take some time to discuss the state of LGBTQ plus health in our community and talk about some effective approaches for engaging LGBTQ plus patients to generate positive health outcomes. And I have the lovely honor of being the moderator for tonight, and I'm super excited to introduce to everyone our panelists. So I'm just going to say a quick blurb about everyone. First, I would love to welcome Anais Cotillas. Anais is a public health professional of Spanish, Mexican, and Filipino descent. She received her undergraduate dual degree in psychology and community health and graduated from the University of Illinois at Urbana-Champaign with her master's in public health. Throughout her career, she's worked in LGBTQ plus healthcare and social services with a focus on health education and promotion. She is currently the coordinator of the Diabetes Care Case Management Program and the co-chair of the Latinx Committee at Howard Brown Health. Her passions lie in working with the LGBTQ plus community, chronic disease management and prevention, helping patients increase self-efficacy, and integrative healthcare. And our next panelist is Dr. Javier Guevara. Dr. Guevara Jr. is a board-certified family physician at Northwestern Medicine and a fellow at the American Academy of Family Physicians. His clinical interests include LGBTQ plus health, academic medicine, and leadership development. He earned his Doctor of Medicine at Northwestern University Feinberg School of Medicine after graduating from the UNC Wilmington with a Senior Medallion Award, a major in biological sciences, and a minor in chemistry. He developed and led Prime Care's health project to become more LGBTQ plus friendly. He's an active member of MOLA, yay, American Academy of Family Physicians, American Board of Family Medicine, Society of Teachers for Family Medicine, and the Illinois Academy of Family Physicians. So thank you for joining us, Dr. Guevara. Our third panelist is Hector Torres. Hector is a clinical psychologist and nonprofit administrator with more than 20 years of experience. He's had the opportunity to engage in the creation, implementation, and supervision of several government-funded and foundation-funded projects addressing health promotion among vulnerable populations. As a therapist, his approach is one that pays attention to human potential, interpersonal relationships, and understanding individuals' context. Hector believes that stigma, oppression, and power dynamics are often responsible for many individuals' distress and psychological symptoms, and therefore addresses these topics in the programs and services provided. And our final panelist is Dr. Ricardo Correa. Ricardo is the Endocrinology, Diabetes, and Metabolism Fellowship Director and the Director for Diversity on GME at the University of Arizona College of Medicine, Phoenix, staff clinician, and researcher at Phoenix FAAFP. He completed his medical school and education master at University of Panama. He completed a research fellowship in epidemiology and tropical disease at ICGES in Panama City and his internal medicine residency at the University of Miami program. He is board certified in medical quality and the author of a book titled Case Report, Basics, and Publication. His research is focused on the study of long-term consequences of hormonal replacement therapy on transgender population and using peer support and telemedicine to decrease the burden of diabetes complications in underserved Hispanic populations. Thank you so much, Ricardo, for joining us. And as we go through with the questions, I want to encourage everyone to fill out the pre-survey, which is in the chat box. And there will be a dedicated Q&A session at the end, but please feel free to send questions to Q&A Kelvin, so that's his name, and just send it to him directly, and then we will go about and ask the questions at the end. So thank you so much to everyone for joining us. And to kind of open it up, I just wanted to give a brief summary or some statistics about the state of LGBTQ plus healthcare in the Latinx community. So a 2018 study from the University of Chicago demonstrates that Latinx millennials are more likely to identify as LGBT than any other ethnic group in America. And as demographics and cultural attitudes shift, it's important that healthcare providers are aware of the unique challenges faced by their Latinx LGBTQ plus identified patients. The barriers include language barriers, religious beliefs, and immigrant status, all of which prevent LGBTQ plus Latinx patients from experiencing positive health patient care interactions. So I would like to direct the first question to Ricardo. Ricardo, knowing that Latinx millennials are more likely to identify as LGBT compared to other ethnic groups, what do you think are the healthcare implications of larger numbers of Latinx youth identifying as LGBTQ plus?
Yeah, thank you so much for the invitation, and Mola for organizing this amazing panel. So definitely the question we have to come from different aspects. So as you mentioned, the Latinx identify as the young population identify more as LGBTQ plus more than an other ethnic group. And the big issue that we face as a Latinx community still is the issue of the tradition and culture that it's going to continue in our community, and the difficult in that culture of accepting different issues with the Latinx. So that conflict internally is still affecting the young population, and it's not just in the US, but it's also in Latin America. So if we compare what is happening here in the US, at least the Latinx community in the US is having a more open situation, and then the fight is more with the family that are a little bit older, and then the acceptance is more compared with the Latin America. If we go to Latin America, I can tell you that it's a totally different situation, where there is no openness in different countries. Compared with others. A little bit of my experiences when I gave a talk of transgender in central countries in Central America for endocrine societies, there was no reception. So the hormone replacement therapy is no, or hormone reaffirming therapy is no accepted. So I think that there is a long way to go. But at least we are giving the first step. I think that the youth is making changes, and this generation is pushing forward the healthcare, and we need to support the next generation. Probably we will see a totally different change in the next 50 years.
Thank you so much for the answer. And I think you bring up a lot of good points about culture and generational differences. And I just want to bring up this definition of cultural sensitivity, which is the ability of healthcare professionals to identify sociocultural differences among patients and to address specific needs without making valuable judgments. And to this next point, Anais, what suggestions do you have for increasing cultural sensitivity, not only among the Latinx medical community, but among medical care providers in general?
Sure, thank you. I have 4 main suggestions. One being by starting by recognizing that, although we have cultural similarities as Latinx identifying people as a whole, we also have cultural differences because we're Mexican, Puerto Rican, Peruvian, Salvadorian, and so on. And so I think that we can start by not only recognizing that, but then in turn educating oneself independently and listening to the narratives of others. I think that has been most effective for me, and personally, is learning and listening to the lived experiences of others, their stories and narratives. And I think we can also work on addressing personal bias and recognizing the machismo and marianismo within one's upbringing. And I think that that's something that we all can relate to as Latinx identifying people. And lastly, I think that we should consider the fusion and integration of Western and non-Western medicine as a way to really bridge the gap for the healthcare, bridge the gap in healthcare for the Latinx community. I mean, we think of our family members and our community who turns to non-Western medicinal practices or healers because it's comfortable. It's a setting that we're familiar with and that we trust. And I think there's a generational component there as well, because we've been accustomed as diaspora Latinos or diaspora Latinx identifying people to Western medicine, and medicinal holistic practices are often stigmatized in kind of these outer circles, and we can only practice that within our families. So I think that to increase cultural sensitivity, we have to, really start by recognizing our similarities and differences, educating ourselves and recognizing our bias, and lastly, considering this fusion of non-Western medicine.
Thank you so much. And you bring up a lot of good points that hopefully we'll touch on more, the machismo, a little bit more of the generational component. But before I do, I would like to ask Dr. Guevara, what special considerations do you as a provider and other providers should take while treating LGBTQ+ identified individuals?
Yeah, thank you for that question. It's an excellent one. I believe what we should all providers always should be mindful about is that what we see in front, the visual that we see does not correlate with the person that they identified as or that they seem to be. We need to be very careful, regardless of age, regardless of skin tone, regardless of what it seems like, if it's a binary or non-binary person, to address them properly without ignoring the previous traumas with the healthcare system, the previous discriminations, right? Even with the legal system, patients being deported or patients having relatives deported, all these traumas, all these previous experiences that may have shaped how they interact with us, we need to be very sensitive and we need to be very open. We cannot judge, and we cannot, based on how we see somebody, based on what they're looking like, groomed, dressed, etc., assume anything about them. Luckily, as a healthcare provider, we have certain levels of interaction with the patient even before our human interaction that can help us, give us an idea, right, of what is supposed to be coming in the next room or whatnot, in the next patient. But even then, I always encourage all of the residents that I train to always be open-minded and just start with broad, open questions, right? And always, regardless, ask, how would you like me to address you? Is this the way that you will like? And always apologize. Many people make mistakes in the LGBTQ and Latino community. We are very understanding of the challenges that this brings, and we appreciate any provider that makes the effort. So we're not supposed to be perfect. Even as a LGBTQ Latinx provider, I'm not supposed to be perfect and know it all about everybody in the same group of community. So I simply apologize, and it's very well received.
Thank you. You bring up the point about traumas that LGBTQ+ patients may face, and several studies indicate that Latinx sexual minorities experience high levels of depression. So Hector, how can providers address mental health issues as it relates to LGBTQ+ identified individuals?
Good evening, everybody. I really like a lot of the points that have been already shared. And I think that this point of humility is essential, right? We cannot be perfect. And there's times that we will make mistakes. And yet, if we're humble enough to acknowledge that, is important. That doesn't take away our responsibility, that if I'm working with someone and someone is sitting in front of me, I have the responsibility to be educated, right? And to do as much good as I can. But that humility is essential to be open to learning about the specific person that I have in front of me. So in terms of depression, the challenge with depression in the Latinx community is that it is complex. And as Anais mentioned in the beginning, we come from different countries. We come from with different identities, and the challenges vary depending on the individual. And the service provider should acknowledge that there are social determinants of health that are gonna impact mental health. So someone may be coming to the office because and expressing their sadness, but we need to go beyond the expressed emotions and behaviors associated to look at the reality of the individual. If this person is facing poverty, if the person is facing the challenge of unstable housing, obviously that depression, I can give the best advice and the best therapy possible, and they go back to a context of stress and anxiety. So for our Latinx community, the constant challenge on a society that has stigma against our population, particularly undocumented population, receive very overt stigma and rejection. We also receive stigma in many other ways, the LGBT community and in the intersection with the Latinx identity. So as service providers, we need to acknowledge that the book test depression is put into a context and addressing the context of a society that is oppressive towards certain populations, that that create conditions that will create health disparities that are greater to certain population is a challenge, right? And that we must address the interpersonal piece and that the depression in the context that we see it, but also know that we need to connect to resources and support individuals in other ways, in a holistic way.
Thank you. To sort of sum up this introductory segment, Ricardo, what would you define as LGBTQ plus relevant care, and why should this be important to us as a community?
Yeah, and I just want to, before I answer this, I want to echo what Dr. Torres mentioned, because we are talking about several taboos in the Latino communities, but two of the big ones is depression. As Latinx, we don't talk about that. So we don't talk about that. We don't know what is depression. So that's one big taboo. And the second thing, we're talking about the LGBTQ community. So big taboo. So two big taboos, and then it comes together, and then there is no way to address. So I think that one important issue is and it's sometimes difficult to find in different places, is trying to find a provider that has some cultural understanding of the issue. And it's sometimes difficult because sometimes you live in a place where you don't find exactly a Latinx provider. But if there is a possibility, yes, it's not only the language, because always when we talk about this, people say, oh yeah, I speak Spanish. Yeah, you can speak Spanish, but you don't understand the culture. So it's besides that, is we as provider that understand the culture, teaching others of our culture, because that's that way we decrease some of that barriers that patients face when they come to the doctor. So going back to the questions about what are things are important in LGBTQ care, it's one is as Dr. Guevara mentioned, Dr. Guevara mentioned, is one is always the medical part. You have you can address it in the later part of your interview. The first part of your interview, you should address the psychosocial part of the person, because this is the part that you can determine if that person is unstable in the situation that they are living, or they're very stable in the situation that they are living. And this is something that I always teach the fellows in endocrine, that we see a lot of the transgender community, is that, yes, for us, it's very simple to do the hormonal reaffirming therapy. That takes us 5 minutes. We review the labs, and that will, in 5 minutes, we can do that. We don't have to, but it's very important to address what are if you are safe at home, who are you supporting person, how the community is supporting you, and all of this, because that part can put you at risk or not. So I think that part of LGBTQ care is very important, and something that as physicians, sometimes we are not trained on, and we just want to address the medical part, and that's it. The other thing is that really we don't have an LGBTQ care curriculum in medical school. Not in PA schools that I teach. I don't know if in nursing school, but in these two areas that the providers are, we don't have that. So really there is no training on how to address certain things that when a patient comes to us, we don't know what to do. And then that's where things like this setting, where teaching others on how to address that kind of things help. Things like creating curriculums where we can spread that into medical schools, into other healthcare schools, that can help, because it's not the same, and everybody in that combination of letters is different. And then that addressing everybody is important. So I think that there is a lot of work to do. There, as I mentioned, there is a start, but at this point, I think that as provider, addressing first that psychosocial part, it should be very important, and then addressing the medical part. But if you just address the medical part, you will miss a lot of the things that probably the patient come with. And Dr. Torres mentioned with depression, that you can miss it totally, and probably the next day the patient die by suicide because you miss all the important part that you didn't address.
Yeah, you bring up a lot of important points, and as a medical student, I think that integrating LGBTQ plus care into the curriculum is vital. And I think now I'm starting to see that more in our integrating the curriculum as compared to like older students. But the part about cultural competency is always difficult to teach. And going into the next segment, talking about the impact of machismo, which is a component that is not insignificant part of the Latinx culture. So machismo is a central cultural theme in many Latino cultures. The definition varies from country to country, but it usually requires men to display physical strength, serve as protectors, and avoid weak emotions like pain, fear, or sadness. And several studies have shown that machismo discourages gay and bisexual men from seeking medical attention and increases their likelihood of experiencing alcoholism and depression. So, Hector, I'd like to direct this next question to you. How can we encourage men who identify with machismo to seek care?
Yeah, and I'm sorry, you asked a question and I answered something else, but I feel that I want to talk about machismo, because also it's important to address these things because we inherit some of the stigma. And when we think about machismo and society think about machismo, think about something negative in the Latino culture. And this toxic definition of masculinity is not specific of the Latino culture, right? It is throughout many cultures. But unfortunately, the Latinos got the prize of getting that word that got very popular and then labeled as the bad people in the movie, right? But this concept, this toxic masculinity, this definition and way of seeing masculinity is global, and it's toxic. It's first binary in the sense that I think about gender expression as something that is binary, or yes or no, good or bad. And obviously it creates these feelings that one gender is superior, right? Not only divided into only two options, but describe the maleness as superior and as the protector. And some of these qualities are great. And there's another term that is much better called caballerismo, and we don't talk so much about caballerismo. So some of these values that we associate with machismo can be positive and used in a positive way. They're about protection and taking care of someone. The problem with machismo is that it's a narrow-minded and narrow definition that is connected with power and superiority, and that creates division among individuals, and that forces people to try to reach an unrealistic image, right? And it's unrealistic to reach, and men are always trying to reach that and pretending, and socially it's important to show that is achieved. So I wanted to clarify that about machismo. But in our society, males and Latino males, we do inherit these notions that I must be powerful, I must be strong, I must protect, and then asking for help is a big challenge. And the being vulnerable is a big challenge. So part of what we need to do is break the barrier of this toxic masculinity, speak about the ranges and broadness of genders, not something binary, and create education so that men can regain their freedom to be broader than this very narrow definition. But that's what we need to do in an educational setting in society. When talking with clients, they may already come with their notion of masculinity, and I need to be respectful. In our Latino culture, we need to be respectful, especially if they're older than me and the head of the family. So I don't start from a place of challenging their notions, but for a place that I respect where the person comes, and that hopefully I have the opportunity to present how this notion can be problematic and impact their health. I hope I answered your question.
Yes, you did. And as someone who's bicultural, Japanese and Mexican, and born in America, I definitely see what you're saying when machismo is not uniquely Latinx. It's part of every culture, but whether it has something like toxic masculinity, machismo, or it goes unnamed is different depending on cultures, but it definitely exists. And you bring up kind of trying to change how we see masculinity. Anais, how do you think we could shift cultural narratives about gender and machismo and seeking medical treatment in the Latinx community?
Yeah, I mean, I think this is a heavy question that could probably have a panel dedicated to it entirely. But when it comes to seeking medical treatment, I mean, we know that Latinx identifying folks are less likely to visit the doctor for a variety of reasons, but one being that, severe distrust of the medical system. We think of Guatemala's US-led syphilis experiments that, left many people unintentionally or, intentionally infected with syphilis. We think of Puerto Rico and the birth control trials, involuntary sterilization, where a third of women ended up sterilized, and a lot of this fueled by eugenics and Eurocentric ideals. And younger generations might not know about this history and these injustices, but they feel the fear and hesitation from a generational standpoint. They feel that fear and hesitation from their parents and their families to seek help from the healthcare system. And there's cultural factors there as well, like the preference for non-Western medicine, a cultural uneasiness with Western healthcare, and traditions of privacy and individual pride. And then when it comes to gender, I think to shift the cultural narrative surrounding gender, we have to look back at our history and examine some of the pre-colonial cultures and civilizations that existed with third genders, trans identities, two-spirited people that are found in pre-colonial societies throughout Latin America and Asia as well, that were accepted and seen quite neutrally. So, you know, it wasn't until really the colonialism and Catholicism that inculcated this violence and stigma and tied it to these identities. So I think to shift the cultural narrative, we need to change our everyday conversation and terminology and further explore our history, which has a lot to teach us.
Thank you. I'm going to shift gears a little bit and talk about Latina members of the LGBTQ community who are similarly impacted by machismo. But as we were doing research on this topic, we noted that there was less research articles regarding the health of Latina members of the LGBTQ plus community. So Dr. Guevara, what do you think is the impact on health outcomes, for example, for Latina lesbians when there is a lack of research?
Right. Yeah, absolutely. That's an excellent point. In my practice, it was hard to see ever lesbian or Latina LGBTQ plus patient. And I can tell you from experience and from the limited data that we have, lesbian women or women who identified as lesbian, they're less likely to go to the doctor for many reasons. They do not like how they're treated. They don't like to be imposed certain screeners, such as a pap smear, that they don't even believe in, right? That they have other notions. They don't feel welcome. They feel that they're going to be judged, very much like any other LGBTQ plus patient. However, in the lesbian community, we see high risks of tobacco use and therefore cancer, higher mortality of cancers from cervical and mammogram, because again, they do not seek the routine screeners as they're supposed to, or we should. And we don't have data simply because it's very difficult to approach them, very much so because of the same things we have done in the medical system, where it's not welcoming, it's not judgmental, it's not tailored to the needs of the patient. As a provider, I can tell you, I also have these pressures from doing quality of care, right? Like you have to have your patient's mammogram done, your pap smear done. So you have these pressures from the system pushing you to do this thing that your patient is not nearly ready to accept, right? And so I feel like the lack of research, the lack of access of care, the lack of interest, are all those barriers. That's why we are not seeing them in. That's why we cannot even research. We have few idea of the disparities based on the research that has been done, but largely comes from wide Eastern European or here in the US studies. And then you add the level or the layer of being Latinx, that even brings a whole other barrier that impacts care. So unfortunately, the data that we know is limited. I think what we always do is extrapolate, right, from what we know from the few studies that we have for lesbian health. And those are usually the topics that we see the most.
Thank you. And I think both you and Anais brought up that distrust that Latinas have for the medical community. So Anais, going back to you, how can us as healthcare professionals address the healthcare disparities among female identified members of the LGBTQ plus community and also try and repair that distrust?
Yeah, well, first I'd like to distinguish that, the term female can often imply biology, whereas women might be a more inclusive term for the community. But I think as a start to address healthcare disparities, understanding that trauma is deeply rooted within the minority experience, especially cis and trans women of color. And some of that trauma, again, coming from this historical corporate or government abuse, like I mentioned before, and things like the Dalkin Shield disaster as well, where a lot of women ended up sterile or infertile and women died from that. And as a part of understanding that trauma, educating oneself and each other, as Dr. Correa mentioned, educating each other, but in this case, on the unique needs of women, and recognizing and acknowledging those mixed experiences of interacting with the healthcare system. And a concrete example I can think of is, assumptions surrounding how women have sex and the uncomfortable situation of having to correct a provider when they assume that you as a woman have penetrative sex, which then leads to, thinking about some of the social determinants of health and really knowing the healthcare disparities and negative health outcomes experienced by women of the community. Some evidence suggests that lesbian and bisexual women are twice more likely to smoke compared to heterosexual women, like Dr. Guevara mentioned. And so I think that to help with the reparation, we can connect the medical and healthcare community with the patient community through the creation of a community advisory board. I think that is something, that is extremely beneficial for our institutions. So I think overall, coming from a place of no assumptions, recognizing the gaps in our own education and understanding, and really using that to grow and continue trying to repair.
Thank you so much. Yeah, I think it's always important to know that you have to grow, you have to keep learning. And that's why panels like these, or just reading a book, are so helpful, or, just taking some time to really try and understand where your patient comes from. Because as we've all heard and throughout this panel, you don't know other experiences of others just because you are Latinx, Latino, Latina. So I would like to transition to the last segment, talking about trans and non-binary identities and their access to healthcare. So as Anais already mentioned, the presence of trans identities has been documented in numerous Latin American cultures throughout history, and early on, trans individuals were viewed neutrally within these cultures. However, the advent of Spanish colonization led to increased discrimination and poor health outcomes for trans, Latino, and Latina, and these effects can still be seen today. So Ricardo, I'd like to direct this question to you. How can we create a more culturally sensitive healthcare experience for trans and non-binary members?
Yeah, so creating a culture, it's changing human behavior, and changing human behavior takes time. Something that I always tell my trans patient is that we have to wait a little bit more. So we are in the process of doing it, but it will take a little bit more. So one of the things is starting with the process that we are doing right now, this big issue of diversity and inclusion. I know that, for example, this year has been a very big movement where the big topic of, besides COVID this year, has been diversity and inclusion, and that has been leading to not only the diversity of ethnicity, but every type on this big plate of diversity, and that include our trans and non-binary community. So that's one of the things on changing the culture, is trying to teach the community, trying to teach the world what is happening, and then that will create more an inclusivity things. Something that is happening, for example, in many admission or job admission, is that they are trying to get data, and it's not to judge, it's basically to see what is the baseline that they have and where would they want to get. And now that you're seeing a lot of chief diversity officer and things like that, not just to put them there for having a checkbox, but to promote this new movement. So I think that we are in the right pathway in the culture. Something in medicine that happened is trying to create more trans centers of excellence. And this is something that in clinics don't happen frequently, and then you see that when a trans patient comes to the clinic, they sometimes feel bad. just because the other patients really doesn't understand yet then. So at the beginning, I think that this is the time that probably we have to create trans centers of excellence where you have a special center where they come. Later on, I don't think that this will be the solution. I think that we have to integrate because everything will be inclusivity. But at this time, I think that they will feel much better. But as I mentioned, I think that we are going in the right direction, at least in this country. We have to work very hard with our neighbors in the southern border. Still, some of them we have to work very hard, but we have to start for some place, and we are doing the correct thing.
Thank you. And as we're talking about ways to treat or interact with trans members of our community, Hector, do you think that using the term Latinx is an effective way to address non-binary and trans patients?
So the term Latinx has been controversial, and so we used to use, we have used Hispanic in the past, and Hispanic as a term is problematic too. It was a term given to us, imposed to us by a census, and we didn't select it. And then the term Latino was embraced more. However, there was a movement to use the X to make it an umbrella term, which is a great framework to think about. Let's not use the binary Latino, Latina, let's be more inclusive. And in theory, the term Latinx is more inclusive, and it means Latino, Latina, and anyone else who under that umbrella. However, some people have worked really hard for their outside to match their inside, and they have worked really hard for that A or O at the end, and their notion of gender is important, their expression of gender is important, and they don't want to be in a term that doesn't celebrate specifically who they are, and they want to be a Latina or Latino. And that's important to respect, that the individual should choose the term that fits for them. Other individuals really push back at the Latinx term because the X not being a Spanish sound and feeling like an Anglo term. So there's many reasons why. In theory, it has a great idea to be an inclusive term. In practice, it has some challenges. I don't think we have the word yet. We're still deliberating, and certain groups have embraced it, certain groups have not. At the end, what we do know through research is that individuals have a lot of national pride, and individuals tend to like to be called and identify with their country of origin. But ultimately, it's about asking the individual, what term do you like, right? The Hispanic term might be oppressive if we think about it, but might identify with that term, and in our interactions, we should respect what the person wants to use to self-identify. I hope I answered your question.
Yes, you did. And thanks for kind of sharing how we should ask questions and how we should not assume anything as we talk to our patients. Dr. Guevara, how else can we create safe spaces for trans-identified individuals who are seeking medical care?
Yeah, that's right down my alley. So like you mentioned in the biography, in my previous employer, Prime Care Health, which is a federally qualified health center in the west side of Chicago for primary care, behavioral health, and substance use services, and dental services as well. When I joined, I knew the company was largely, or had a lot of LGBTQ members of the community, even in the leadership positions, but the clinics themselves did not reflect that. And we knew that we had trans patients and LGBTQ plus patients, but we did not, when we run reports, could find accurate data. Patients were not feeling comfortable enough to self-disclosing their gender identity, their trans status, or whatnot. So these open up the great opportunity to lead this change. How do we become more LGBTQ plus friendly, right? And I wish that there was out there some sort of organization that can come and give you a stamp of, you know, LGBTQ plus expertise or whatnot. The Human Rights HRC campaign has a degree for certain companies, and they give you this, depending on how you score, right, that title, but it's not dedicated directly or only for health centers, much like we do for Medicare Center of Excellence, et cetera. So a lot of it is sort of what you develop your own to be, what you can form. What we did was form a community, a panel, a committee of inclusion, diversity, and LGBT friendliness of different members. And we didn't need only LGBTQ plus, we needed also allies or people who even differ from that, because we need to hear from every aspect of that to say, okay, as an organization, this is what we believe in, and that we need to provide, and that we believe everybody deserves care regardless. So this is what we need to do, and this is what we're going to embrace. And so how do we do that? A lot of it is, major things are, one, visualization. LGBTQ plus patients will research 10 times before they actually make a connection to a healthcare provider. Meaning they're going to go on websites, they're going to go to social media, they're going to go to bars, they're going to go even to friends to find out where do they go, who do they trust, and where they can find those services. Making yourself visual in many places will make you feel and project that you are LGBTQ plus friendly. Two, like I said, visualization, it goes under that as well. Make your logo, your branding, your clinics, your space LGBTQ friendly. If you only have, and everybody in the LGBTQ plus community most likely will look for those cues, a pride flag, a rainbow flag, a trans flag, and it doesn't have to be massive, right? Even just one in the door and in the lobby. That your bathrooms are inclusive. If you just have male and female, well, what if that doesn't fit me, neither one of those, right? And train all your staff. So that's what we did. We brought Fenway Institute to help, and Howard Brown to come and train from front desk staff, providers, PAs, dentists, et cetera, et cetera, et cetera, et cetera, everybody on basic terminology, pronouns, and we had to revamp our entire intake forms so that we can reflect all those extra things that we in our community for diversity and inclusion identified, right? And what the literature, what we could find that tells you ways of making your practice more LGBTQ friendly. So I think visualization, I think education, like we kept repeating through this panel, educating everybody, and an honest conversation with everybody in your system that can help you become more trans and LGBTQ plus accepting.
Thank you. And as you bring up this point about education, Ricardo, how can we specifically raise awareness or educate the older Latinx healthcare providers that may not be as familiar with trans or non-binary identities?
Yes, that's a very good question, because we have this in everywhere. It's in the healthcare providers. And I can tell you that in the endocrine world, where we are the ones that are in charge in the majority of the cases on the reaffirming therapy, we have older endocrinologists that they don't know about this, and they don't feel even because they was not in their training. So So I think that the way to educate is, one, it's something that we don't like it, but it's put in there in the recertification exam, putting this topic in the continuing medical education. So because everybody in, for example, in medicine need to take a recertification exam, need to take a CME's credit per year, need to take in the license, sometimes need to have some of the things. This had to be included in that. And more for the specialties that need to take care of this community, and more focusing in internal medicine, family medicine, endocrinology that need to take care of the trans community. So that will be one of the steps. I know that it's controversial because then nobody likes to do exams, and that's another problem. But the next thing is always trying to bring all of these issues to all the big meetings where everybody participates, older and newer generations. So all the national meetings, the specialty society meetings, all of the, and having at least a research topic for this. And this is kind of happening. For example, there is always a special topic for trans at the American College of Physicians. I met with Dr. Guevara, the American Academy of Family Physician, in the Endocrine Society, the American Association of Clinical Endocrinologists, always have to be a topic on trans medicine. So there is already that. And then I'm trying to create more in the ethnic groups. And this is what MOLA is doing at the level of National Hispanic Medical Association. For next year, there will be a topic on trans medicine, because it's important to this older population to start teaching them what is happening with the newer population. So that's, I think, that a way to go in education.
Thank you so much. And I think that's all the time that we have for just these questions. I want to leave plenty of time for the Q&A portion. So Calvin, I think, has been receiving the Q&A. So if he would like, he can ask the questions that the audience has been asking.
Absolutely. Thank you so much for that, Erica. Good evening, everyone. So it looks like we have time for a couple of questions. I just wanted to let you guys know, if I don't get to everything, we will have an opportunity to send out answers via email for you all. So our first question is going to be, should there be a change in medical education where social science backgrounds are given equal weight as hard science backgrounds? And this is for all of the panelists.
I would say yes. I think then we're talking about 6 years of medical school, because I'm a strong believer then that the health is impacted a lot by psychosocial, economical aspects. So we do need to address those. We need to be better at that. However, the limitation is always as well, that would also require perhaps hour-long appointments, and I don't even know how will that be received from both ends, the patient and the physician. So ideally, yes, I think what needs to be happen is that evaluation of how do we incorporate this even more, right? How do we incorporate LGBTQ education more? How do we incorporate social studies even more so than just scientific? You do want your physicians to be expertise in the sciences, right? You want your doctor to be able to know the anatomy, physiology, pathology, but you certainly want a human, someone that understands those social aspects that would impact your care. Whether that's in pre-med, whether that is in medical school, whether that is in residency or longitudinal, that's something that ACGME, the accreditation entity, and AMA, and all these entities that have the guidance through this should discuss. But I believe it is a yes for me.
I'd like to, I agree with Dr. Guevara. I really think that it's important, and throughout my MPH education, we had several clinicians who were in my cohort who found it very beneficial to have that background, to understand the individual influences, the relationship with their community, with their society, whether it be, you know, societal and cultural norms, how they interact with their neighborhood, their schools, their workplace, or their family and their peers. And I think that we can give it that weight by creating more integrated healthcare teams, by including social workers and case managers, and really integrating and including those additional resources to really give more holistic care.
I also want to comment a little bit because I think it's a great idea. And at the same time, as a psychologist, I think this topic should start in kinder and first grade. So also we should review our education in elementary, middle, and high school, and some of these, instead of repeating some subjects over and over, we can go into depth of how we relate to other human beings. How do I relate to myself? How do I learn about me, about mental health, and society, oppression, and all those topics. So I love the idea of medical school, but also let's start early. And also it's important that that we give the seriousness to cultural competence that they deserve. So I don't go to an allergist to operate my heart because we understand those specializations as important and concrete. And when we understand that cultural competence is as important and concrete, and we take responsibility over the education. And if the school doesn't give it to me, which it should, and if the licensing board doesn't take the step, at least I know that if I have someone in front of me, a human being in front of me, is my responsibility to educate myself, to be able to provide the best care possible to this person. And they're very concrete tools for populations. Today it's an hour, we cannot go over some of those, but there's concrete tools, and cultural competence is something concrete that that can have a great impact in clients coming back, clients improving, and client having ownership and being empowered to be more engaged in the health care.
All right, thank you. Ricardo, was there something that you wanted to add?
No, I think that something that I really like, it's the longitudinal curriculum. So not just in the admission part, I think that it's important, and you should valorate in the admission part both the science and the social science. But if you don't get it before medical school, it have to be longitudinal from UME to GME, and this the entire. And there are certain medical schools that are doing this from the longitudinal curriculum, and they have been very successful.
All right, thank you so much for adding. Our next question. So we touched a little bit upon trans and undocumented issues. The next question involves becoming more welcoming for Latina sex workers and disabled patients. So what is the best way to go about creating more inclusive and culturally competent environments for Latina sex workers as well as disabled Latino patients? And this one is also for all of the panelists.
And I can start with some ideas. And you know, once I heard this example that when we were thinking about bathrooms, if we're thinking about bathroom and privacy in bathrooms, and we were thinking about the challenge of trans individuals being forbidden to go to the bathroom that they should go, and the fear of people reacting to that, it was because it's because of stigma. But in the solution, when we address the solution for the most vulnerable, that solution can be applied to other populations. So for the bathrooms, if privacy is an issue, creating stalls that are that have walls to the floor can be helpful for protecting privacy. And I'm giving this example because the same example, the same stall that may help for trans and GNC individuals to feel safe and protected and that have enough privacy can also serve for someone with a diverse ability. So I'm saying this because what we need to think is when we look for solutions for the most vulnerable individuals, those solutions can apply to other populations. And when we think about creating program spaces, services, we need to think of the most vulnerable, open that door, make it safe and accessible to the most vulnerable, and then we will have greater likelihood to accommodate multiple populations.
Great.
I think I would add to that a lot of the also efforts that we have tried to do is meet them, not expect them to come in, especially Latina sex workers and Latino patients with different abilities or disabilities will not most likely come into you for many reasons, right? So what we have always tried to also use is the mentality or the thought, if you know they don't come to you, you come to them. So parent with other organizations, the City of Chicago IDPH, and provide those services, the night ministry bus, places that you can go for services that come to where they are working, right? And be able to, and it's very well known that they are more likely to accept, hey, we're here. Would you like to be tested today for HIV? Or would you like a meal? And let's talk about this, right? Pairing with all those services that we can also approach them and bring them in and give them a list of resources. Well, next time you need anything, please contact this provider. This provider is willing to see you, etc. So there are very few services, unfortunately, but there are some. And again, one of the things that you can do to make yourself more open and available is reaching out, not just expecting them to come to you.
Wonderful. Ricardo, Anais, did you all want to add as well?
I love the idea of, meeting people where they're at. Clinical spaces can be very intimidating, especially for these populations. So I really like the idea of meeting them where they're at in a more comfortable.
I agree with that, yes.
All right, wonderful. So I'm gonna move on to the next question. So how can medical students / medical professionals be better about advocating for these changes that we talked about within the panel?
Yeah, so I think everybody in this audience that is listening to this or that is participating in this can be an advocate for any of this. I hope that this, as you can see, we are starting the conversation, so we're carrying on the conversation, and it's huge, and we can all do a little bit to go that can go a long way. So medical students, organizing medical interest groups, participating in conferences, MOLA, Howard Brown, Center of Halsted, etc., reaching out to, if there's no such organization in your medical school, to go ahead and create it, to seek out advice and mentorship. During medical, the residency, the same. We have always electives, be able to select those electives. I did my elective with Howard Brown, especially for that same reason. I understood that the standard curriculum of family physicians did not incorporate those services, and I was interested in that. So again, reaching out, not expecting for it to come to you. And patients advocacy, going to the Illinois Department of Public Health, Chicago Department of Public Health, and asking for these services, right? Lobbying as residents, as doctors, and medical students, the Illinois Academy of Family Physicians. We have an advocacy group that goes to Springfield, right? And we are looking to make these changes. So if you're passionate about anything, contact your local, your school, your associations, any of us, right? And we should be able to provide lists of ways of how to directly make those advocacy happen.
Yeah, and advocacy is big, and I think that any healthcare professional, besides doing their job, it's another of our job is to protect our patients. And a way of doing this, I always think that is having a voice on the table. So one of this is being involved with organized medicine, and it can be from your local to the regional to the national organizations, and creating resolutions, creating things that will make some changes, things that you believe that will bring something to your patients, to your peers, to better for their community. And another thing that Guevara mentioned is being an advocate is also trying to go. People always make things that make the confusion between advocacy and politics, and it's totally two different things. If you go to your state Congress and Senate, or you talk to your governor, or you go to the national Congress, the federal Congress, and you talk to the Secretary of State or anything, that because you believe on that's an important part. That's the only way that we can make changes. I can tell you a very good example on advocacy coming from organization was gun violence. So I don't know if you remember that in 2017, there was a tweet coming from the American College of Physicians about gun violence. And then because of that tweet, the NRA came and said, this is not your lane. And because of that, millions of people, of physicians say this is our lane and start bombarding. And 2 years later, in 2019, Congress approved $20 million or more, $20 million in research on gun violence. So it took 2 years, but it took a tweet to create all the snowball at the end and this was just advocacy from even social media. So if you're interested in a topic, use all the resources. Now we have social media. So use social media as a way to advocate for what you believe.
And advocacy means many things, right? And advocacy can be to speak up and question things and ask questions. I in my education, I had been told that LGBTQ people were sick and were not in the DSM because a political issue. And I had to react to that. In my education, I've been told that Latinos don't go to therapy because X or Y. So we are always often in situations where speaking up can really help, and that's a way of advocating. There's many ways, from not buying a product to sometimes the most radical thing that you could do is listen someone and really get off your pedestal and be humble and learn and give that person the opportunity to be heard. So I think all of you can engage and should engage in advocacy and find the means that can really contribute